Alright, you guys, welcome back to yet another awesome video here on the channel. Now today's topic is going to be a little bit different for me. It's going to be a little bit more research based than probably any other video I've done so far, because we're going to talk about a specific class of drugs that are used psychotrophically, and this topic is going to be all about atypical and typical antipsychotics. So before I even begin anything, it's probably important that I start this whole video off by saying I am not a mental health professional. I'm not a pharmacology student. I'm just a person who has multiple diagnoses, BPD, bipolar 2, generalized anxiety disorder, and panic disorder. So I have years of dealing with all that, and I've been on many different medications. Only one of them has actually been an antipsychotic, and I had horrific reactions to that, as I've discussed in previous videos. But I am not a medical professional of any sort. This video is not for any sort of advice or anything like that. So let's get on with the subject, shall we? So first, what we're going to do is we're going to look at just overall classifications of different psychotropic meds. Again, it's just going to be a quick overview, and then we're going to jump over to the specifics of the antipsychotics. So here with this is my handy dandy chart that I found right here. So as you can see, there's many different ones on here. Of course, we're only going to talk about the antipsychotics today, but we also have antidepressants. Everyone's heard of those, but of course there are many different subtypes and different categories of them. That will be the next video, most likely, so keep your eyes peeled for that, because there's a lot to go over with them as well. We have mood stabilizers. We have anti-ADHD, which is really just stimulants. And then anti-anxiety, the anxiolytic medications, like benzodiazepines, Xanax, things like that. So now that we kind of looked at those, I have another quick chart here just kind of illustrating some different examples of each of these categories, some FDA approvals, what it's on paper designed to be used for, a few off-label uses as well, for treating other symptoms that are not official, to be used officially in that capacity. And then of course some of the side effects. So you can pause the video, look at this a little bit closely. I know it's a little small, but this is just kind of an overall thing. We're not really going to spend any time on this, because we're going to go into the history real quickly of neuroleptics, which is just another name for antipsychotics. So where in the world did we come up with these things, right? Well, you might think that medication's been around for a long time when it comes to, psychiatry and things like that. But actually, it's really new. It's literally started in the second half of last century. That's it. This stuff is less than 100 years old. And it's really sad, but also really beneficial that these medications did emerge when they did, because before medications, like all of these ones that we're going to talk about, things like schizophrenia and bipolar disorder and all sorts of other mental disorders, there were really no medication options. So really what we see is a lot of procedures and long drawn out treatment plans. This of course included lobotomies. Dr. Walter Freeman was basically at the peak of lobotomies when the first antipsychotics were coming out, and basically is the only reason that his methods basically were kind of sidestepped and kind of looked at negatively after the medications kind of caught up to some of the treatments that were going on at the time. You know, in addition to just that, there was also, you know, ECT, the electroconvulsive therapy. We discussed that in several videos. Insulin, shock therapy, basically injecting massive amounts of that to cause seizures, same general idea. Hydrotherapy, just a lot of big experimental treatments, you know, long drawn out things. But medication is really what changed all of this and got people away from institutionalization and these barbaric treatments. So these are relatively new. So that's just something to keep in mind. When we talk about the very first antipsychotic that ever came out, of course it came out as an accident, as many things in the world, especially medical field, you know, that's how things are discovered all the time. It was discovered in 1952, right? It's called chlorpromazine. Thorazine is the brand name. And basically this was referred to, when it first came out, as a chemical lobotomy. So this was a huge, huge stepping stone. Because like I said, this is the very first antipsychotic medication of its kind to treat the negative symptoms of schizophrenia, which are the ones that you usually think of, the hallucinations and delusions and things like that. So this was a game breaker, right? Another drug we see a little bit later on is haloperidol, which is Haldol, it's the brand. This is another very popular first generation, came out in 1958. Both of these are really primarily only used today in the inpatient hospitalization setting. Probably because they are very potent, some more than others, but they're still very potent, and they can be given through an injection, which in a case of an inpatient situation is often needed if they can't take pills, you know, by mouth, or won't. But either way, that's really where we still see these two used. Now, there are many other first generation ones. There's about 10 of them, I think, total listed on my my genetic testing sheet. But these are really the two big ones to focus on. The other ones I really never hear of in researching all of this. So these are the big two, right? And we'll discuss more about the first generation specifically in the next slide. So what we see next is the introduction of the very first second generation, the atypical classification. Now what's interesting about clozapine here, or Clozaril, even though it is regarded as the first second generation antipsychotic or neuroleptic, it actually came out in 1959. But generally when we think of classifications between typical or atypical, it's usually just by date. Basically anything after 1970 is considered atypical, and anything before is atypical. But obviously clozapine is technically the big exception to this rule. And we will definitely be discussing that one in much more detail at the end of the presentation because, well, you'll just have to wait and see. But it's a big deal. And then, of course, just in the 90s all the way through the 2000s, we continue to see the emergence of many more second-gen antipsychotics. Risperidol, Abilify, Zyprexa, so many. We'll discuss more of them specifically coming up after this. So on to just some of the specific side effects and things we see in particular about the first gen, the typicals. Like I said, the two big ones we're going to discuss for this category are chlorpromazine and haloperidol. Now Thorazine is considered to be a low potency when it comes to first gens, and Haldol is considered to be high potency, one of, if not the highest potency out of all of these first generations. Now, like I said in the beginning of the video, I am not a pharmacology person. I have very limited understanding of how these medications work. But essentially, if you just need to have some sort of definition or some sort of reason of how these work, basically the only important thing to note is that most of these first generations work on the dopamine 2 receptors in the brain, and they are an antagonist for that. And that's the method of activation for most of these. What's most notable about the side effects, though, for the typicals, the first generations, is the extrapyramidal symptoms. These can be pretty severe. It can often start out as dystonia, which is muscle spasms. It's kind of like a lack of facial expression. Your face can get stuck in a particular expression. That's kind of like dystonia. You have akathisia, which is a general feeling of like restlessness, unable to sit still, constantly fidgeting and moving. Your hands, your eyes, your legs, whatever it may be, cannot sit still. And then finally, and most importantly on this list, we have dyskinesias, which are movement disorders. The most serious and severe one that I bet a lot of people have seen commercials and ads for is tardive dyskinesia, or TD. Now, what is most severe about TD is it can often be permanent. Now, typically we don't necessarily see TD progress until much later, after years of long-term exposure to a typical neuroleptic. And of course, the more potent that particular one is, the more likely your odds increase. I think I heard somewhere that there's like a 10% chance of developing TD for every year that you're on a first-gen neuroleptic. And like I said, this can often be permanent. The only real thing you could do in this case is try to decrease the dosage. Because of course you can't stop cold turkey, especially not with drugs like these. These are very, very serious drugs. But even still, they can still be permanent in a good percentage of the patients who present with this eventually. And another thing also worth mentioning in terms of another side effect that can be life-threatening is called neuroleptic malignant syndrome. And this can be life-threatening, like I said, very serious. And this can include things like high fever, confusion, muscle rigidity, changes in blood pressure, and an elevated heart rate. You can also have like high blood potassium, kidney failure, and seizure activity increase as well. And they say this can occur with any neuroleptic, whether it's typical or not. But of course, it is more typically seen in the typicals. So if you want a way to remember it, there you go. So that's enough on the first gens. Let's go on to some of the more recent adventures we've had. So you might not have heard much about the typicals in daily life if you've ever seen any of these advertisement commercials or anything. But a lot of these are very, very common. Basically, every one I have listed is all stuff I hear about all the time. Of course, like I said, the very first second gen is clozapine, even though it was not developed in the 70s or later. We also have olanzapine, which is Zyprexa. That in particular is a very high potency, basically only second to clozapine in terms of effectiveness and potency. And we'll cover that in a little bit. We also have quetiapine, which is called Seroquel. That's the brand. That's known for knocking people out. A lot of people are on that. It's very sedating, apparently. I haven't been on it, so I can't confirm. But we also have risperidone, which is Risperdal. And the only one on the list that I've actually been on that's an antipsychotic is aripiprazole. which is Abilify, which we all know I had horrific reactions to. Yeah, it was not good. And in fact, all my genetic testing, every single neuroleptic is ruled out. It's marked in the very right column. It says like adverse reactions or poor response is indicated for every single one of them. Typical, atypical, doesn't matter. It ruled out entire classes of drugs for me. So luckily I've only been on one that I had horrific reactions to, but I can't imagine what being on something even more potent would do to me. So luckily we know that now. But anyway, the mechanisms of actions, like I said, I'm not really going to go into that. A lot of them aren't really known because these are much newer. A lot of these came out in the 90s. And Abilify wasn't FDA approved until 2003. So that's probably one of the most recent ones on the list as far as what I've ever read. So unfortunately, the thing about newer medication is you don't have nearly as much research. You don't have lung-based trials and lung-based, records of, extended years of taking these medications. So that's, something to be aware of course. But one of the things that we see with the second generation is generally people say that they have a decreased risk of these movement extrapyramidal symptoms, that we see so much with the first generation. So that's certainly a plus if that is indeed generally true. But of course, they still do carry a risk for an increase in hyperglycemia and insulin sensitivity. Weight gain is noted to be a particular problem with all antipsychotics, but in particular the second gen can be notorious for it. Olanzapine, I've heard, Zyprexa is like the worst for that. I think I was reading something, someone said they gained like 50 or 60 pounds in a few months from this medication. That's how severe it can be. So it's not really necessarily that it's 100% safer just because they're newer medications. Like I said, in fact, we don't have as much research on them just because of that very fact that they are newer. So time will tell just how effective these are, especially when everyone compares them to the first generation, antipsychotics. So, like I said, I'm not a pharmacology person. I have very little understanding of any of the stuff I read when it comes to how does this stuff work. But really, just a quick understanding to kind of put at least some of this together. There's really two main neurotransmitters that are involved in these medications. This is the same for antidepressants as well, although there's a few more for them. Really, the two here are going to be dopamine, which is basically the reward or pleasure feeling neurotransmitter. So this really, like for gambling and spending money, that rush that you get of, oh, I had to keep playing now, I had to keep winning, it's a rush of dopamine, which tells you need to keep gambling, keep spending money, whatever it may be. And that can lead to a lot of the addictive behavior because of that feeling. But of course, decreased dopamine levels are what are often thought to be a cause of many of the depressive and psychotic symptoms, the low energy, the feelings of hopelessness, and the anhedonia, which is the loss of pleasure that we see in depression a lot. And the other big neurotransmitter worth mentioning is serotonin. Serotonin affects mostly mood processing. So of course, naturally, that leads to a lot of the mood variability in different mental disorders, bipolar, depression, all of these things. And just as a side note, like I said, the next video will be specifically on antidepressants and all the different classifications, the SSRIs, the SNRIs, TCAs, all of it. I've already been doing a lot of research for them. I've been on many of them, so I kind of have more of a clue with those. But just a kind of a perspective, the SSRIs stands for Select Serotonin Reuptake Inhibitor. You don't need to know what it stands for necessarily, but it is kind of helpful in explaining what it's for, what it does, what it's supposed to do. So basically just SSRIs in general, they increase serotonin levels. And a lot of them do that by blocking dopamine receptors. So then your level of serotonin increases, therefore your mood increases. That's generally how they work. Not a pharmacologist, but that's it. That's basically just a quick understanding thing. So now we're going to get on to the big drug out of all of these, right? Clozapine. I said we'd come back to it, but I didn't tell you why, because it's more interesting to find out now, isn't it? What is so big about clozapine is it is used exclusively as a treatment-resistant drug. It's a treatment of last resort, is what they technically refer to it as. There are several drugs that are on that list of being a drug of last resort. This is one of them when it comes to treatment-resistant schizophrenia. That is the only exclusive FDA treatment for this. Like you can't use it for bipolar or something else. It has to be schizophrenia. And one of the criteria to even begin being eligible to be prescribed clozapine, to start it, is you have to have at least 2 or more antipsychotics that you tried before and did not have optimal results with. Another really interesting thing about clozapine is it also carries 5 separate FDA black box warnings. This is more than any other psychotropic medication that I've ever heard of. And we'll cover those, what they specifically are, in the next section. But just to know that there's a lot of warnings that come on this. And black box warnings are the most severe warnings the FDA puts on medication. And we'll see those in the next slide. Another thing that is really interesting about being able to be prescribed clozapine in the first place, is if all this other criteria isn't enough as it is that both the prescribing doctor and the patient both have to be put into a special registry of all people who are prescribed clozapine. And they're put into this special program called Clozapine Risk Evaluation and Mitigation Strategies Program. And the reason for this is because they have to keep track of who's prescribing it. Because of all the warnings and everything, it's so severe, they have to be licensed to prescribe it, the doctor does. And then they have to be put on this specific program, this registry, this list, where they keep track of every person that's on this medication, who's prescribing it, where it's being prescribed at. You know, the clinic themselves have to also be authorized apparently to do this. And then here's the other big thing for why that's so important. They're also keeping track of the results of weekly blood testing that you have to have done in order to be given this medication. Yeah, weekly medication. And guess what? You're only given a supply of 7 days worth of medication at a time, because you have to show backup for the testing to get your next dose. So what were those 5 black box warnings, you say? The first one is going to be probably the most severe, and is really the biggest thing they're looking for when it comes to the blood testing each week. Because the risk of developing a granulocytosis, which is a low white blood cell count, is very, very fatal. Because you need white blood cells to fight infection. If you can't fight infection, if it drops below a certain number, it can be fatal. And so you would have to discontinue the medication entirely immediately should this come up in your labs. We also see an increased risk for seizures. That's obviously important. We see myocarditis and cardiomyopathy. Myocarditis is just inflammation of heart muscle, and cardiomyopathy is an enlarged heart. And obviously these are both cardiovascular issues. There are several others as well, but these are just 2 that were mentioned specifically. Another black box warning is for orthostatic hypotension, which is a rapid decrease in blood pressure when you're getting up out of a chair or your bed or something like that. And that can be with or without syncope, which is fainting. And then finally, the last black box warning is an increased risk of death in elderly patients with dementia. Now, this one basically in every single psychotropic drug, most antidepressants I've seen this on, mood stabilizers I've seen this on, the one I'm on now I've seen this warning. So this is very common. These medications just don't interact well. Often it can cause death due to the cardiovascular issues that we just talked about up there. But just in general, a lot of these really potent medications are to be avoided in elderly patients with dementia or psychosis. They should not be treated with this medication. And actually, I was able to find a label of clozapine that actually specifically says, it's hard to read, let me see. It says, it is recommended that drug dispensing should not exceed a weekly supply. Dispensing should be contingent upon the results of the white blood cell count. So there you have it, officially on the label. They're serious. So that's enough about clozapine. So let's wrap this up. So hopefully you learned something today about antipsychotics and kind of different forms of them and how they're used to treat different mental disorders. If you found the video interesting or helpful, it'd be great if you leave it a thumbs up, like rating. And of course, don't be afraid to subscribe to the channel. I'll have a link somewhere here to do that. If you don't want to miss any more awesome content just like this, breaking down mental health confusion and myth-busting sort of things, and try to be very educational and entertaining in the videos. That's why I do this. I'm not an expert. I'm just a patient that has a lot of interest in what's going on. And that's about it. So I'll see you in the next video, which will be on antidepressants. Until then, see you next time.